Welcome to this edition of Pulse on Health. I'm your host, Mark LeMay. GLFHC is home to one of the only healthcare for the homeless programs north of Boston and serves locations not just in Lawrence, but throughout the Merrimack Valley. Joining us on this edition of the program, Dr. Ryan Dono, one of the providers involved with the program. Welcome, Doctor.
Thanks for having me.
Let's start with a broad overview of the healthcare for the homeless program and why the program is so important.
Sure. So our program, maybe to lead, I'll just quote you our mission statement that the team had created. I think it kind of really talks to the mission behind what we do and why we do it. So our mission statement is to promote health, hope, and dignity for those affected by homelessness by reducing barriers and increasing accessibility to comprehensive, high-quality, respectful, and empathic healthcare. Our team functions as a multidisciplinary team of interdependent clinicians, nurses, medical assistants, and community health workers, whose purpose is to serve in solidarity with those living with poverty and homelessness, and through this kinship, work together to eliminate health disparities. And so that's kind of the mission behind our program. Our team consists of 7 doctors and nurse practitioners. We have a few medical assistants, a nurse, and community health worker. And we kind of work as a cohesive unit and provide care in Lawrence, Lowell, Tewksbury, and in Haverhill. We provide care to approximately 15 unique sites. 3 of those are drop-in centers, 9 are shelters, both for single adults and families. 2 are food pantries, and we also provide services, our community outreach center at 100 Water Street through the clinic. We provide care both inside the shelters or food pantries, and then we also provide care through our mobile health unit for places that we cannot set up clinics within the actual sites. And our mobile health unit really is like a normal clinic. It has 1 or 2, depending on which one we're using, full exam rooms that have kind of the usual kind of bells and whistles that any clinic would have. So we're able to kind of provide the same amount of care that we would in our brick and mortar continuity sites as we do on the mobile unit. As far as kind of the type of care we provide through our providers, for the most part, we provide broad spectrum kind of family medicine based care. We provide routine primary care for folks, including management of their chronic illnesses, access to birth control. We do urgent care visits and are able to do basic procedures if you have an abscess or need an injection in your knee. For example, we also provide mental health prescribing and linkages to care, addiction medicine services. We provide access to buprenorphine and treatment for opioid use disorder, cocaine use disorder, alcohol disorder. And then we also are able to provide care and treatment for patients that have hepatitis C and HIV. Outside of the routine kind of clinical responsibilities that we also have our team of kind of support staff does a significant amount of outreach, providing vaccination clinics, both for kind of routine vaccines, but also COVID-19 vaccines. And also we've been able to offer routine kind of testing for COVID-19 to the sites that we're serving. And then perhaps the most important service that we provide is through our community health worker. And that's really kind of addressing the major kind of obstacles to care with respect to getting folks access to insurance and ID cards and licenses and reliable housing and much more. So that's kind of us in a nutshell, I would say.
I'm going to share a quick story with you. A few years ago in my previous life in the communications department, I shadowed one of your providers, Elaine Lee, on a trip to one of the shelters. And she introduced me to a patient who wasn't previously homeless. She lost her job because of diabetes. She was apparently a school bus driver. And she apparently couldn't use her feet anymore to drive. So then she became homeless because she didn't have a job. And one quote has stuck with me since then. We are all 2 paychecks away from being homeless. There are some people who, maybe I'm wrong, and you can correct me if I'm wrong on this one, they choose to be homeless. They choose to be independent. There are others who fall into the homeless category through the grace of God. We'll just say that. How do you work with this sensitive population on a day-to-day basis? And dare I say, not get discouraged with society?
Gosh, you bring up a lot of emotions with that whole story and comment, you know. I think so frustration with society, no doubt, comes as a result of doing this kind of work. What I think, I can guarantee you that all of our providers don't have frustration is working with the population. And those are 2 separate things, right?
Yes.
Homelessness can happen to anybody. We're all 2 paychecks away, or a natural disaster, or a catastrophic illness, or a break in our mental health away from being homeless. And it always is important to think that homelessness can have lots of different definitions as well. We immediately think of people who are out on the street and living in encampments and outdoors, but there's a whole host of other individuals that suffer from homelessness or housing instability that are in shelters or double or triple boarded up in apartments, and kind of all face similar issues at the end of the day. I would say the thing that draws me to this work and draws our whole team to this work is that we get to provide care to those individuals who face this stigma of homelessness. And as a result, we can kind of battle those injustices that structurally are existing in our society that kind of put people there. I don't think anyone truly ever wants to be homeless or live outside. I think when your options are limited, and you have a complicated history that might have a significant amount of trauma in your life, the draw to staying in a shelter can be a really traumatizing and horrible experience. And so perhaps living outside is a much better option for folks. And it's a complicated mess that housing really has created for everyone. And so yeah, it's a complicated thing. And I think there's so many things that our society puts in place to that make it difficult for people to get out of that circle of poverty and homelessness. And it comes from stigma and judgment and things like that. And you know, at the end of the day, the most important thing we can do is advocate for those patients and communicate with our legislators and leaders in the community to kind of help work towards finding solutions. But it's really complicated.
Why is it important to bring healthcare services to the patient, such as homeless encampments? I mean, one of the phrases I kind of cringe at is "under the bridge," but there is a unique population that lives in that neighborhood, and I put neighborhood in quotes because there's definitely a society, a neighborhood in those encampments?
So bringing care to people, I think, is essential, because there's a lot of unseen obstacles that maybe folks who aren't in that situation don't realize. The first is to get into a clinic, you often need an ID. It's often expected that you have health insurance, not necessarily at our wonderful clinic, but the perception is often there that you have to have insurance to be seen in a clinic. And then when you're homeless, and especially if you're unsheltered homeless, there's the stigma of poor hygiene and people judging you, that comes when you come into a brick and mortar site. Add that to the fact that there's a large portion of individuals that have a significant history of trauma. And coming into a busy clinic with lots of people around you and lots of questions being asked, and for you to show up and be present in that moment can be a very challenging obstacle for folks. Whereas when we bring care to them, either in our mobile unit or even on foot, we could hopefully lower a lot of those barriers that are preventing people from making that step towards getting medical care. And if we can lower those obstacles, then we're probably more likely to engage and help them find solutions to the issues that they're having.
This is sort of a loaded question, but what are some of the healthcare issues you see among the population you serve? And what are some of the barriers to treating someone who is considered homeless?
So to the first part of the question, I would say the medical problems that I treat in our homeless clinic versus in our regular clinic are probably the same. Medical disease isn't necessarily picks one person or the other to kind of infect with diabetes or high blood pressure or cancer or any of those, or mental health disease. I think things get amplified when you're homeless, and your ability to manage those things becomes much more complicated. At the end of the day, I think the major kind of defining obstacle or issue that is present for our homeless patients is things that come along with social determinants of health. And so by that, I mean access to food, especially healthy food and reliable food options, access to a reliable income. If you don't have your identification cards and things in place, you're less likely to be able to get kind of disability or other kind of means of having a reliable job. Housing stability is uber important. And if you don't have stable housing, how are you going to possibly store your medications, either that need to go in a refrigerator or safely so that people don't take them? Safety and exposure to trauma is incredibly increased when you're outside and living in a shelter. And so those issues always take priority over someone trying to manage their high blood pressure or manage their insomnia or manage their chronic medical problems that need attention. And so if you can't meet your daily basic needs, then trying to pay attention to those other medical problems is really complicated and difficult. And so that's the major obstacle, is really addressing those issues and trying to find solutions to really difficult answers, or difficult questions rather, is the key to trying to level the playing field, so to speak, for folks that have the same medical problems that aren't homeless.
We're talking with Dr. Ryan Dono, one of the providers involved with the Healthcare for the Homeless program at Greater Lawrence Family Health Center. We're going to take a quick time out. When we come back, we're going to continue our conversation with Dr. Dono right after this. Welcome back to this edition of Pulse on Health. I'm your host, Mark LeMay. We're talking with Dr. Ryan Dono about the Healthcare for the Homeless program, part of Greater Lawrence Family Health Center. Doc, one of the issues facing the homeless population is a distrust of society, and that distrust can extend to the medical profession. How do you, as a provider, regain the trust of a patient that has no reason to trust you?
Yes, it's also a complicated question. The roots of distrust, I think are complicated. I think it probably is a result of kind of the structural or institutional kind of forces that are at play. And when you're in the chaos of poverty or homelessness, the the likelihood of faith that you can put into those organizations or structures is difficult. So I think people come with kind of a sense of being guarded at times when they enter healthcare. The most important thing that we can do as a team when we see our patients is to really approach things kind of from a trauma-informed lens. I like to put it is trauma-informed care doesn't necessarily apply to just trauma, but I think it's a way of providing care that's empathic and understanding to the patient's current set of needs. And so really we need to be very careful about passing any sort of judgment on people or letting people feel that there's some sort of stigma when they come get care with us. And really the most important thing is listening and listening to patients' stories and what their needs are, rather than me kind of telling them what they need to do to be healthy or improve their health. I think probably one of the leading areas of why people distrust medical institutions is they're often told that they need to do this or they need to do that. But if we don't understand that they can't do this or that because it's simply impossible due to the current situation, then we're never going to get anywhere. And so really it's listening to patient stories and accompanying them on their path to wherever they feel like is the most likely way to get success is the most important piece of that, I think. Yeah.
One of the things that we stress at Greater Lawrence and throughout community health is mental health. It's an important part of good overall health. How are mental health issues addressed in a mobile setting?
I would say that they're approached in a very similar fashion to a normal clinical setting. I think the most significant obstacle here is that access to reliable mental health counseling and support is extremely limited in the community. And when you're someone who's dealing with homelessness, the likelihood that you can coordinate getting into those appointments is probably significantly more difficult than a normal person per se. And so a lot of the time our clinicians are in the place where we have to provide that initial care, at least, if not all the care for their mental health. We really try our hardest to link people into counseling and therapy, but oftentimes we're the first line as far as figuring out where to go with their medical management and prescriptions for those things. And I would say my approach is probably no different than it is in the clinic than it is in the mobile setting, in that really it boils down to kind of just what we were talking about, that kind of trauma-informed and patient-centered care, where you're truly listening to the patient and letting them kind of have a space that's safe to share kind of what their issues are. And sometimes that can be a little bit more complicated when you're providing care either in a shelter setting or a drop-in center or in the mobile unit, in that privacy can be a little bit more complicated. And so really ensuring that we have safe spaces for people to feel comfortable in sharing what they need to share is the priority and super important.
Let's be clear. You don't have to be homeless to be seen at one of the GLFHC mobile health units, because some of the locations you set up at are best known as transitional housing.
Yeah, so as far as who we see in our homeless program, I think the most important thing is that we make no judgments on anyone, and we really try and lower obstacles to care. And so transitional housing or unstable housing, shelters, or the unsheltered are all welcome, and we really try and lower those obstacles to allow anybody who needs to be seen to be seen. If you're kind of stably housed and in your own apartment, we often will try and encourage folks to be seen in the clinic, but we don't have to necessarily put that obstacle to get access. If you need access at that point, we'll still see you and kind of work with you going forward.
At this point, I would ask if somebody needs to have insurance to be seen, but I know firsthand, sometimes one of the things the staff does in the mobile health unit is to get people going in the right direction to get basic necessities like a government ID or insurance coverage.
Yes. So again, kind of our goal in providing care for folks is to lower all those obstacles. And so luckily we have funding from both kind of a federal standpoint, but also a significant amount of funding from some wonderful kind of nonprofits that support our services. And so we're able to see patients without the requirement of insurance. And if folks don't have the ability to pay for their medications, either through their insurance or out of pocket if they don't have insurance, we have a program set up that if they use our pharmacy, we can make sure that they get their access to the medications that they need without having to pay for anything. And so right from the onset, once we see folks in our homeless program, our goal is to link them with our community health worker to make sure we start getting those processes in place for insurance and for getting their IDs, because it's essential. While we can still provide kind of access to routine kind of primary care, access to specialists is even more complicated. And so really, if we need to get them in to see the oncologist or the ophthalmologist or the cardiologist, then those providers often will require insurance unless you're going to go to Boston, and asking our homeless patients to get to Boston can be a big ask and really complicated. So
GLFHC actually has 2 mobile health units. Why are these important?
So, the mobile health units are a remarkable intervention that has allowed us to access patients in previously inaccessible areas that maybe wouldn't come to see us in the shelter or in a food pantry. But it also allows us to go to places that need us on a whim. We don't have to set up a structural clinic site that is approved by HRSA to see patients and things like that. And so really the mobile units give us an ability to access our most vulnerable and kind of isolated patients in a patient-friendly way. And then the fact that we have 2 of them is pretty essential as well. Our current mobile unit is out every day of the week, and we fill it pretty quickly with our homeless responsibilities, but we also are trying to do other things in the community, such as access to COVID vaccines and COVID testing, and we also visit some of the schools with our school-based health center programs, and there are other community events that require engagement, and the ability to have the mobile unit at those is also really powerful as well. And so when you add that all up quickly, if one unit goes out of service, then we're really hurting. And so having that second unit is also really essential when the other one needs maintenance, because if you needed to get maintenance on a vehicle for a week, if we were to stop services for a week, that would be catastrophic. And so really the 2 units are quite essential into making sure that you can maintain operations for sure.
Let's talk a little bit about the staff that remains stable as a result of trust issues that the homeless community has towards society. Again, I use the term God's work with what the homeless program staff does.
Yes, our staff is probably the most important thing that we do in our care. For example, when Dr. Waite who's one of our more seasoned providers, if he disappears for a short while and I fill in for him, and I show up at one of his routine sites and a patient shows up to see Dr. Waite, they're very upset when they see my smiling face. And it's consistency and reliability and getting to know and trust people that's really important in the work we do. And I can't tell you how many patients have come to see me for an acute issue that they probably need a doctor for, like chest pain, but they only want to speak to the community health worker because she's the one that they trust. And when we work as a team, then she can make sure that that patient gets access to me and gets appropriately cared for and has the ability to trust seeing me. But if we're not all working together and we're not there reliably and consistently, then our patients don't have that trust that they do. And it's incredible, the providers that we have on our team, from top to bottom, from doctors to medical assistants to the community health workers and to our support staff. Everyone's there to serve that mission and really be attentive to patients' needs, and they do incredible work, and I'm blessed to be a part of it.
And last but not least, what got you into being part of the Healthcare for the Homeless program?
You know, my motivations in becoming a doctor really were motivated in decreasing disparities and injustices in our world. And I've been given an incredible privilege to become a doctor and to be able to take part in individuals' stories and help them work through their medical problems and to be able to extend that service to our society's most vulnerable or disadvantaged population is a true gift. And I wouldn't give it up for the world. It's the most valuable thing I do, and it fulfills me at the end of the day and makes everything all worth it. And I would honestly, I would rather spend my full day working for the homeless than doing anything else. And it's a treasure. It's amazing.
Well, to you, to Dr. Waite, to Elaine Lee, who, as we shared a story off air, I followed her, I shadowed her for a day, and all the staff. Thank you for what you do day in and day out, no matter what. So we really appreciate it.
Thanks so much.
And that'll just about do it for this edition of Pulse on Health. For all of our podcasts and radio programs, feel free to visit our website at glfhc.org. Until next time, I'm Mark LeMay. Have a healthy week, everyone.